Good morning, this is Dr. Minasri. Today we'll talk about ECG in anesthesia. We'll cover fundamental principles, perioperative monitoring, ECG leads, very important to know, a quick step-by-step way to read an ECG, key pathologies, and anesthetic pitfalls. The ECG shows the heart electrical activity. Depolarization moving toward the electrode makes a positive wave. Repolarization moving away makes a negative wave. What we see in the ECG is the sum of these electrical waves. Conduction starts at the sinus node, AV node, His bundle, and Purkinje network. So ECG is mandatory in operative and perioperative monitoring, helps detect rhythm disturbance, monitor for myocardial ischemia, and identify electrolyte abnormalities. In practice, we use 3 standard leads, red, yellow, and green, for all patients. For cardiac patients, we add 2 more leads, black and white or green. There are different mnemonics to memorize the colors and their placement. So D2 and V5 leads are recommended. D2 helps see P waves and inferior ischemia, while V5 detects anterolateral ischemia, as demonstrated in numerous studies. For this, alarms are continuously set for ST elevation over 1 mm and corrected QT above 440 milliseconds, because these changes are linked to serious events. For ECG leads, it's important to remember the precise positioning. V1 is placed as 4th intercostal space next to the sternum, V4 at the 5th intercostal space mid-clavicular line, V5 5th intercostal space anterior axillary line, key for detecting lateral ischemia. Lead 2 runs parallel to the right atrium, is ideal for analyzing P wave. For technical setting, paper speed is 25 mm per second, and calibration is 1 millivolt equals 10 millimeters. This is the first step in analyzing an ECG and should never be skipped. First, check if the rhythm is regular or irregular by measuring the RR intervals. In sinus rhythm, each QRS is preceded by P wave. Then calculate the heart rate using the formula. P wave morphology provides specific information about specific heart condition, like right and left atrial hypertrophy. The PR interval is short in Wolff-Parkinson-White syndrome and prolonged in AV block. P wave is pathological if it is deeper than 1 mm and more than 25% the size of the R wave. It may indicate myocardial infarction or heart tissue damage. The QRS complex duration and amplitude important. Normal duration is between 0.08 and 0.12 seconds. When the QRS complex is widened, consider hyperkalemia, local anesthetics, sodium channel blockers, and arrhythmic drugs. This sign is a recognized sign of local anesthetic toxicity, indicating impaired cardiac conduction. Then we assess the ST segment and T wave, looking for signs of ischemia or repolarization abnormalities. Finally, we assess the corrected QT interval to detect the risk of torsades de pointe. For key pathologies, the 3 emergencies to recognize are ischemia and infarction in different territories, anterior, inferior, and lateral. Conduction disorders include AV block, bundle branch block, and bifascicular block. For arrhythmias, we need to recognize atrial fibrillation, which shows no P waves and irregular rhythm. Ventricular tachycardia shows a wide QRS complex and is often regular. Torsades de pointe is a specific type of polymorphic ventricular tachycardia, usually linked to a prolonged corrected QT interval. We need to stay alert for electrolyte imbalances like hyperkalemia, which causes peak T waves that can progress to a sine wave pattern in severe cases. Hypocalcemia also can prolong a QT interval, Antiarrhythmic drugs can prolong the QT interval. These include class 1A agent like quinidine and procainamide, and class 3 such as amiodarone and sotalol, and they increase the risk of torsades de pointes. Digitalis promotes AV block, and succinylcholine can induce bradycardia, especially with repeated doses. In case of pre-excitation syndrome or Wolff-Parkinson-White, we should avoid sympathomimetics in the perioperative period, especially if hemodynamic instability occur in Wolff-Parkinson-White patient. Procainamide and amiodarone are preferred to manage arrhythmia safely. Electrical cardioversion remains the treatment of choice if unstable. A complete intraoperative AV block requires immediate preparation for transcutaneous pacing. Sinus arrhythmia, especially under spinal anesthesia, carries a risk of severe bradycardia, which necessitates therapeutic anticipation. Thank you.